On behalf of the Society of Minimally Invasive Cardiovascular and Thoracic Surgeons of India, I welcome to the fifth module in a series of skill development courses. We had a earlier minimally invasive mitral valve surgery on 9th of February. We had a minimally invasive aortic valve surgery course on 13th of February. Then we had a minimally invasive coronary artery surgery, 13 March, surgery for thoracic aorta, 27th, and today is the 5th. Subsequently, we are going to have management of cardiac arrhythmias on 24th of April, transcatheter aortic and mitral valve implantation on 8th of May, and endovascular stenting of thoracic and abdominal aorta on 22nd May. I'm sure they would like to join in these upcoming events. I am on behalf of scientific committee which constitutes Dr. Anubhav Mule, who is the vice president of the society, Dr. Rajiv Malhotra, secretary, Satyaki P. Nambala, Ajit Bana, and all the executive members. Welcome you all in the event of minimally invasive cardiovascular and thoracic surgeons of India events. We have fortunate today to have two great legends in the field of heart failure treatment, Dr. Sebastian and Dr. Herman Richard Spooner, who happen to be a past president of ISMICS as well as the past president of ISHLT. And Dr. Sandeep Atawar is going to introduce them. But before that, let me also welcome the Dr. Atawar, who is going to co-moderate this session with me. Dr. Atawar has few months back moved from Global Hospital Chennai to Sims Hospital Hyderabad. He's now the who's who along with other colleagues like Dr. Gokhale, Dr. Bala and all in the field of solid organ transplantation. So Dr. Atawar is there to co-moderate this session. Then we have also one international panelist, who is Dr. Nicholas Doll. He is going to be joining from Germany. Then we have Dr. Ala Gokhale. He's the chief of the group of Apollo Hospital group, and he is the lung and heart transplant surgeon. He's also the program director and senior consultant cardiothoracic surgeon, expertise in minimally invasive and of course heart transplant and lung transplantation. Welcome, Dr. Gokhale. Then we have other panelists, Dr. Keval Krishna, who is the director, heart transplant and left ventricular assist device, Max Super Specialty Hospital. Then we have Dhiren Shah, who is director, cardiovascular surgery at Sims Hospital, Ahmedabad, Gujarat. With this, let me invite Dr. Sandeep Atawar to introduce Dr. Sebastian.
Thank you so much once again for the honor. I would like to introduce Dr. Sebastian Schultz-Eistrup, who was born in 1966 in Bielefeld. He's a German citizen. There are some keywords that could describe Dr. Schultz. That is, he's an innovative, transactional, dedicated, determined, enthusiastic, team-oriented teacher who is largely autonomous and thinks out of the box. I mean, if these are words that can probably describe him best. He did his medical school and graduated in the year 94 from the Wilhelms University of Münster. He went on to obtain his license to practice medicine in the same year. He also underwent training at the Hanover Medical School, where he graduated as a resident in trauma and orthopedic surgery. He went on to specialize in heart surgery at the Heart Center, North Rhine-Westphalia at Bad Auenhausen in Bochum. Between 95 to April 99. He went on to complete a fellowship at the Baylor College of Medicine and the Michael DeBakey Department of Surgery in Houston. He worked in the Artificial Organs Laboratory under Yoshihiro Noze between April 99 to May 2000. He went back to Germany between June 2000 to May 2011, where he worked at the Heart Center, North Rhine-Westphalia, Bad Auenhausen at Bochum, where initially between 2000 to 2008, he was part of the advanced heart failure and heart transplant team as a team member, initially a resident, later a fellow, and subsequently staff. He graduated and excelled in whatever he did, taking on and assuming the responsibility of being the acting manager of the Department of Advanced Heart Failure and Mechanical Circulatory Support and Organ Transplantation in the same unit, with additional responsibilities in managing corresponding critical care units, and also with great deal of interest in not just telemedicine and the surveillance of vitamin K in anticoagulated patients. He then assumed the full chair position at the Heart Center of Osnabrück from May 2011 till January 2021 at Bad Rothenfeld Schudemann's Clinic for Cardiac Surgery, as initially the staff surgeon for heart surgery, and later on as the program chair for advanced heart failure and mechanical circulatory support. He was also in the interim, the interdisciplinary heart failure clinic head at the same center. He's now seemingly moved on to also be a consultant for MedTech Industries from January 2021. Ladies and gentlemen, I have for you Dr. Sebastian Schulz-Einstrup. It's a great honor to introduce him. Thank you very much.
Well, thank you very much. This is an introduction I've never had so elaborately. Thank you very much, Sandy, really. I appreciate and being here, and it's always it's fun to be attached to India. You know, my experience lasts now for more than 10 years, and it's I really value your society and your friendship. I'm really delighted to be invited. You know, I've got a hot topic, you know, the hot topic, less invasive VAD implantation. It's something we can chat about, but something that we just have to talk about very seriously, because there are so many rumors around in this area, and the introduction, the early introduction demonstrated already there's a lot of room for discussion. So I hope we can I can walk you through the current status, and then we may have some time discussing how we should deal with this, how we deal with this specifically in a one-to-one fashion here on the meeting. Oh my goodness, how can I advance? All right, let's do this way. Okay, these are my disclosures now. And as I said before, in being introduced, I'm an independent consultant of MedTech Industries. Since I'm currently transitioning between two positions, I will not refer and demonstrate any scientific data, clinical data, or images from my former employer. And I would like to especially thank for this presentation, Professor Jan Schmidow, who is heading the Department of Heart Failure and Medical Devices and VADs in Hanover Medical School, Professor Stefan Fischer, who's a thoracic surgeon in the northern part of Germany, and Dr. Alexander Bernhard, who is chair of the section of heart failure transplantation at the University of Hamburg, and Ali Kilic, who's the senior account manager by Medtronic. So what are we talking about? The less invasive implantation, and well, not everybody is really familiar what's going on, but I assume there is. So we started off calling it a minimal invasive one, but you see here on the right hand side that there is a 7-centimeter incision at the upper end of the sternum, whereas there's another incision is made at the apex of the heart. So if you just add them up, so you come up to, let's say, 14, 15 centimeters of skin incision. And this is completely in contrast to what you consider to minimal invasive and the rest of the world as well. So we divide it now into a sternum sparing surgery, which is either partial or total. And I think the secret of the merits of this approach is that the pericardiotomy of the right ventricle is not done fully, rather partially, or even not at all. And all in common has an apical access of the apical access to by the anterolateral thoracotomy. Pictures are shown by given of courtesy of Professor Schmidow. In the beginning, where the first reports were in the 2012 by Schmidow and Struber about the minimal invasive use of the hardware, those days was still called hardware. HVAD and cosmesis was a major issue, and you see on the bottom, you see that what happened, how patients look like after they have been implanted with a VAD minimal invasively. Whether that's of any importance, everybody has to decide for himself, but at least we started off as being that as an important point, but we soon realized that other issues become more into play. Surge leaky, I think, from what the introduction of all the participants are here, we see that everybody is very well known to what's going on. We have here either we have either hemisternotomy up to the third intercostal space with the J sternotomy. We can just make a parasternal opening of the thorax right in the second intercostal space. We make a left entry or a left anterolateral thoracotomy. We bring out the driveline as we usually do, either with a subscaphoid incision or encounter incision, or bring it to the left or the right. We do it on pump. We can do it on pump with arterial femoral cannulation or ascending aortic cannulation. Over here, you see on the left hand, on the middle box, we see, okay, the HVAD in place, how it is used, how it should look like, how the outflow graft is pushed forward within the pericardium to the ascending aorta. On the right-hand side, we see a little secret, and we start off with this one, that the pericardium should be closed by whatsoever, because the transplant surgeon will be very grateful if he goes in and has to explant the heart with the apical mechanical circulatory support and has no adhesions to the left lungs, which occur rather frequently. If you do that in a minimal invasive way without respecting the anatomical boundaries, you cannot just close the pericardium as some would like to do, because you congest the left ventricle and push up the LVAD into the pericardial space, which has no way to go, and you will have a separation of the papillary muscle and induce mitral valve failure, as well as tricuspid failure, most likely right heart failure as well. This is just a suspicion from my side. It cannot back it up with any kind of literature. So here, to be able to perform minimal invasive or less invasive surgery, we need to have special tools. And Medtronic provides these by looking here. This is the coring knife. It had been extended. The screwdriver is extended. This is a very normal scenario, as you see over here. This is the opening left anterolateral thoracotomy, and this you see how the opening, the apical knife is brought into place, punching out the left ventricular apex to insert the LVAD. And look at these here. Look at look at the silk over here, the silk tires over here, the silk ties. They are kept in place in order to manipulate the apex to exactly the area where you want it to have. Since being on bypass and having the left ventricular apex opened, you always have an issue that it just diminishes and falls into the pericardium, and you have a hard time just bringing in the LVAD quickly. And you don't want to air the ventricle too much. You rather would like to have it de-aired, so you want to do it quickly. And looking at here, you will very much appreciate that this is certainly not a minimal invasive surgery, and it's more appropriate to call it less. It can be done with the HVADs as well as the HeartMate 3. Here there's a series with the left apex exposed in a dilated heart. And you see very easy here that you can place the apical ring without any difficulties in a globular deformed heart. But please appreciate that if you have, let's say, an infarcted heart with a more conical shape, it's not that easy to administer the apical sewing ring where you don't find a nice plane as in this one to position it to. So you need to fiddle around a little bit to find the best place by using the echocardiogram, or may use even a puncture needle to see how the VAD might look like when it's in place. It has to be in place as seen on the left-hand side by looking at the chest X-ray, which is perfectly placed. A mal-placed VAD has been made responsible for a lot of issue, including unfortunate less unloading, pulmonary hypertension, thrombosis, and failure of the therapy. So there are specific device considerations when you start doing this, and you have to realize what is the best device for this. Basically, it can be done with both. it can be done as with an A thread as well as in HeartMate 3, but you see that the HeartMate 3 in the middle is a lot more bulky than the H thread is. So the H thread is very slim, nice to place, and it goes into nearly every cavity, whereas the HeartMate 3, and you also have to appreciate here the titanium outflow graft, which is very, very rigid, may be cumbersome to place. The graft protection here, and this is a video from Professor Netuka, just recently published, and it's a screenshot, has been pushed inside the pericardium to be able to manipulate the device more freely, to bring it into place without having to lever too much at the apex of the heart, bearing potential danger for injury. Interesting here as well, you may recognize that as well, here Professor Netuka has made the outflow graft anastomosis to the ascending aorta prior, but it can be done either way. Of course, this is a schematics how moving from the apex now to the sternum. This is a schematics from Scott Silvestri and Ed McGee, where they just demonstrate that you can also go on bypass by cannulating the aorta directly. They still use a venous drainage via the femoral vein, but you can also do that directly without any issues. You just make a standard, anastomosis to the ascending aorta when using the hemistenotomy approach, and this is the most mainly used approach. You can also do it when you just have a mini thoracotomy in second intercostal space after having dissected the right internal mammary. Bring it in on the lateral side, on the convex side of the aorta without any issues. So another approaches are the subclavian artery. Subclavian artery is favorable, can favorably be reached by the hardware H-wedge due to the size of the outflow graft, which is 10 millimeters, but it's very hard to anastomose the 10 millimeter outflow graft to the axillary artery. So usually that's it is baffled down to an 8 millimeter graft. So the 8 millimeter graft is firstly anastomosed to the axillary artery, and then after the 10 millimeter graft had been exited at the second intercostal, they can be anastomosed in an end-to-end fashion. Please appreciate that the axillary artery should be partially ligated distal to the anastomosis to prevent a brachial overflow. On the right-hand side, you see a study was published in the Journal of Biomechanics a couple of years ago, where we just looked at the flow phenomenon, the subclavian artery versus the ascending aorta on the left side, and you see the watershed phenomenon that we all know in ECMO patients here in the subclavian artery directly at the trunk, whereas here in the standard cannulation of the ascending aorta, the shear stresses and the shear stresses displayed over here is a different, meaning that, of course, flow characteristics towards the head are very much dependent on the watershed phenomenon, as we know in ECMO patients, and here in the ascending aorta is completely easy. The issue, of course, remains at the aortic root, but this is an unsolved problem so far. Furthermore, we looked at the shear stress here. At what angle you should anastomose the graft to the axillary artery, and this is 90 degrees, and obviously there's a lot of shear stress. 30 degrees fine, but we'll never make that anatomically, but 60 degrees is something we can go for, and this is a 60 degree, and you have least shear stress, and it even gets less when you ligate or partially ligate the axillary artery distally. So that's how it should be done. Another one, and that is an interesting approach as well, it's also minimal invasive, is towards the descending aorta. It was very popular in the Jarvix, and it was the primary way to do so. Now it is more or less a reserved option for the hostile sternum, hostile mediastinum, and the hostile ascending aorta, as seen in this case, which is heavily calcified. It's something that you cannot stumble into. You have to prepare that very meticulously at the beginning of the surgery, bringing the patient to a full right-sided position where you have to have a thoracotomy extending more towards posteriorly, and you have to do, and this is very much advisable, do the descending aortic anastomosis prior to inserting the pump into the left ventricular apex. It can be the outflow graft anastomosis can be next to the diaphragm or next to the subclavian artery, whatever is best. It did not make so far any difference, but it should not be a 90-degree angle. This is a very, very recent abstract seen in the JHLT from the Özbaran group from Izmir in Turkey, who used this in the descending aorta anastomosis in 58 cases. And there's a lot of data on it, and I just would like to highlight the differences is making it easier and quicker. And you can very much appreciate that the ascending aortic group is younger, which is just 50 years versus 58, so it's highly significant in their cohort. And of course, the descending cohort is more diseased by ischemic cardiomyopathy and being reoperated with 100% previous tenotomies, whereas the other ones just had 11%. So it's a very, very different cohort. Interestingly as well, when you just appreciate the liver function parameters differ as well significantly. So it is hard to compare these groups, even though you mostly done, and we just see this throughout the entire presentation, that there are cohorts compared that clinically seem to be different. Interestingly as well, when looking here at the functional, not the functional, at the echocardiographic morphologic parameters of the tapsy of the right ventricle, they differ, not significantly, but to some extent. But these are, especially on the descending aorta, a severely impaired right ventricle. The numbers cannot be read here, but I would just like to show that, you know, the p-value and mortality, which is on this side, is not different. And the adverse events are neither different. So we see that with the descending aorta, a similar survival can be achieved here in this group of 280 versus 58 patients in a contemporary setting in an experienced center, which Professor Özbaran in Izmir definitely is. So now, Yugal, this is for you, because I just heard yesterday that we're doing robotic cases. I remember this should be shown as well. So there have been some attempts to use this also to use the robot also for the implantation of VADs. It certainly can be done. This is an off-pump procedure where you bring out here the driveline first. Interestingly, these authors recommend to bring in the pump first and then make a robotic anastomosis of the outflow graft with 4 ports, as a stab wound in the intercostal 1 here for the side biting clamp, and 3 robotic ports. It can be done. This is just done very seldomly, and so far not very popular. But there may be some chances for surgeons who are experienced in doing so, but not even every center has a robot. Okay, now after having introduced now all the surgical issues, we just have to, I have to bore you, I hope not to bore you, I have to just draw your attention to some on the status in which we are currently are, so we can look at the issues and the possible merits of less invasive implantation of a VAD better. So what's the global status right now? And this is derived from the IMAX registry, which is an ISHLT-based registry incorporating data from 35 countries. It's Intermax, Euromax, Japanmax, UK registry, and 4 independent hospitals provide these data directly. So this is really the largest cohort one can have looking at real world data within our mechanical circulatory support group. Interesting, you see, of course, the largest contributor is Intermax, and Intermax is mandatory for all Americans. So the contribution of the Americans is the largest, definitely. And over time, and this is now the data acquisition finished and was up to 2017, and we see here that the actual flow pumps in orange are on a steep decline, especially in Europe and the US, whereas the centrifugal pumps take over and take the lead. Talking to the company's representative, this is not the case in every single country, and this is certainly not the case throughout the entire world, since since both centrifugal pumps are not approved in every country, and of course there are financial constraints leading to the implantation of the HeartMate 2 with definitely not bad results further on. Looking at here now the survival, we see that with the axial flow pumps versus the centrifugal flow pumps, one is in red and the other one is in blue, are not significantly different up to, or are nearly the same up to 24 months. Looking here at the INOMAX status, it's been throughout the entire period at INOMAX status. Level 1 has the worst result, and this has not changed. And whereas 2, 3, and 4 are significantly not different. Looking at the application of INOMAX status throughout the time from 13 to 17, you see it has not changed either. So we do realize that INOMAX level 1 is the worst to come along with, but interestingly, we have not, or at least globally, the attitude has not been changed. Game changers came into play in 2017 and 2019 with the centrifugal pumps approved for DT, and both of them are approved for less invasive implantation. So it's very hard right now to give a good literature overview post 2019, because that's the from 19 on we have the current devices in play, and we can only give a overview of what's going on currently with having both of the centrifugal pumps being reported on. Sticking to this presentation, we see over here that over the time globally, all the patients are at risk, and we see look at all these early hazard rates. If it comes here to the later hazard rates, we see that, of course, all the patients, and especially in the US and in Europe, the patients get all over time are risk patients. The Americans are, I don't know why, but at least it's displayed over here. And of course, here INOMAX patients 1 to 3, as well as destination therapy, and destination therapy is the one, at least in the US and Europe, that's on the rise. What do they die of? And of course, neurologic dysfunction, multi-system organ failure. Now we come to a point that is very hard to look at, and this is the right heart failure. It's axial flow 11%, centrifugal flow 10, and overall 11. And we see over here how are they counteracted. And this is the blue bar is the isolated LVAD, and reacted promptly on a right ventricular failure necessitated an RVAD. You have better outcomes than placing the RVAD later, but within 14 days, or even later after 14 days with catastrophic survival rates. So it is in this cohort, isolated LVAD is 83%, which I think is very excellent. And then we have an LVAD and simultaneous RVAD dropping below 60, and if just goes to below 40, 35 if not reacted promptly and correctly. So right ventricular failure remains an issue here. It's just 11%, but 11% requiring RVADs at any kind of, at any stage in the post-operative course. But interestingly, can we now impose all the data throughout the world? No, certainly we cannot. Just looking at here survival dates, you see the Asian Pacific region is the best one in red. So your survival rates are favorable over the European and over the Americans, and we see that these are cohorts that can hardly be compared. Over here, Asia Pacific is 750, whereas it's 13,000 US and 2,000 European. The Asian population is hardly morbidly obese or obese; it's rather underweight or non-obese, whereas that's different in US and in Germany. Or no, Europe, I'm sorry. Others, so and we see over here as well that the use of centrifugal versus axial flow pump is different in the US, more axials, and Asia as well, where the centrifugal pumps have been introduced into Germany, into Europe earlier. So these cohorts are so different. And looking at the problems at right ventricular failure, there's hardly any right ventricular failure in the Asian Pacific cohort, where it is definitely higher in Europe as well as in the US. So it cannot be compared. So thinking out of the box, meaning, in order to talk about a global status, we somehow have to harmonize data even more so that we can give global recommendation how to do what in which scenario. Looking now here at, this is back now to INOMAX. What can we achieve as survival over here? Transplantation and BTT are in parallel in the first 20, at least in the first year, maybe in a year and a half. Then so far we see this is 16, and what is published in 20. We see that transplant takes off. So still transplant is a phenomenal therapy, and of course many VAD surgeons proclaim VADs to be as equal as a transplant, and this is certainly a matter of debate. But we can achieve very, very good results over here as published by Zimfer over the 7-year period, with having a 50% survival rate over 7 years by the hardware HVAD, and with implants from 09 to 12. Now we just dive into right heart failure, because right heart failure is supposed to be less invasive VAD implantation, and we see that's an early problem. Here on the graph we see the freedom for first right heart failure over time, and over the time of 6 years, and the over 35% experience some kind of right heart failure here in the, this is the fully magnetic levitated pump in purple, which is the HeartMate 3, and the HVAD is here in the dark purple. So there is a right heart failure right now of 35% within early post-operative period, and it starts, and there's still late right heart failure contributing to the clinical scenario. There have been multiple efforts to predict preoperatively whether a patient will jump into right heart failure post-operatively, and most of them are non-consistent or reproducible, and nothing one can rely on. So this is still a black box in which we work all the time, and we have to deal with spontaneously, even though, of course, a massively impaired right heart failure by a TAPSI, let's say of 10 or hardly any injection anymore, precludes an LVAD, but that's sure, and that's obvious to everybody. But patients that are deemed to be suitable for a left ventricular assist device therapy suddenly end up being in right heart failure, which needs to have some maybe even intensive efforts. So looking at here, this is a multi-center trial recently published in Circulation Heart Failure in 19, where the right heart failure INOMAX definition of 213 are applied. These are 4 centers for 370 pages, 70 pages with a mean age of 57, 54% are BTTs, and implant periods from 8 to 16. So this is what we actually do right now. And look at here at the schematics, 72% experience right heart failure directly post-operatively using the right heart failure INOMAX definition of 13. And this is the elevated central or right atrial pressure in right heart catheter. Not everybody has a right heart catheter in place all the time. As a dilated jugular vein, a dilated inferior caval vein, elevated jugular vein. So this is ranging from 8% to 63%, and peripheral edema, ascites or palpable hepatomegalopathy, and an increase in bilirubin and creatinine. So if they occur, and inotropes can be weaned within the first 7 days, it's just a mild right heart failure, and this contributes to 35%. If it can be weaned, the posture of inotropes, nitric oxide, and vasodilators can be weaned within 14 days. It's moderate. If it extends past 14 days, it's severe. And if a mechanical surgical support is needed, it's severe acute, and severe acute is 9%, whereas severe in itself is 13%. So we have 24% of severe and severe acute right heart failure in a cohort that was implanted electively at experienced centers. So this is quite a bit, and this gives us a very good clue on what's going on. And we see over here that the right ventricular stages, mild and moderate, are not really important because they have the same outcome as the non-right heart failure. It can be managed, but it has to be managed by dedicated therapy and dedicated intensivists who deal with this problem frequently and know what to do. And the cumulative survival starts to drop if the inotropes are extended beyond day 14, or if an RVAD needs to be placed. And this over here on the bottom side, on the bottom graph, you see that it's the odds ratio 4. Looking at the multivariate analysis, there's not really much to look at. We see that, of course, age is an issue, INOMAC status issue, and SPAP versus this the ratio of SPAP with stroke volume. This makes a lot of sense. So now we move to the ARC definition of 2020, where the severe acute of the 13 and the early acute and post implant right heart failure are nearly the same. So, but the early and mild stages have been discarded. Interesting here, looking at the primary diagnosis of right heart failure, we have an additional now of the SVO2 of less than 50. So the patient going into a low output phase. The cardiac index drops between 2.2, and the pump flow reduces of 30% of the previous baseline and absent from mechanical issues. This is very interesting. So it means these patients have to be monitored very, very intensively and carefully and invasively as well. Now we come to the lateral and the lateral approach. And well, everybody I think is aware of what's going on with the lateral trial. It's a multi-center prospective non-randomized single-arm trial in the US, solely the US, of 144 patients served by an HVAD. These were solely BTT patients with severe right heart failure being excluded. The primary endpoint was 180 days alive, recovered, and explanted, but explanted due to recovery, nothing else, transplanted, and freedom of stroke with a modified ranking score of above 3. Secondary endpoint was the length of hospital stay. So it's a rather, well, what would you say? We would say it's a rather healthy cohort with 55 years of age, a normal distribution, cardiac index of 2.1, and all were BTTs, and the primary endpoint was met in 88.1%, hardly any strokes, and hardly any disabilitating strokes. The 2-year survival came up to 87%, and interesting here as well, and the severe right heart failure requiring an RVAD was 0.7%. And just going back, we recall that it was 9% in the previous publication. So that's a dramatic difference. And this contributed now to even more interest into the minimal invasive approach besides the anecdotal approach of single centers. Now the group of Bartlett Griffiths looked whether it can also be applied in high-risk patients, where it had the less invasive case, high risk, identified by the Cormer score, whereas this high-risk cases in a conventional sternotomy versus a non-high-risk case. And we see over here as well that there were distinct differences, but what I found very interesting, even though they were deemed to be high risk, the albumin is still 3.3 or 3.4, and we very often see that the patients who are in severely distressed have an albumin reaching 3 or even going a little bit lower, and these are the ones that also cause problems if you do it minimally invasively or less invasive, because these will have recurrent pleural effusions that need to be tabbed and sometimes end up being in empyema. Interestingly as well, here the ones that is the conventional sternotomy had more VA ECMOs, obviously here it was chosen to use them rather than the lateral thoracotomy. I think this is a dramatic bias, and this is a dramatic bias. Interesting, operatively, we see that the intraoperative use of red blood cell counts was significantly less in the less invasive versus the conventional, and the blood product use as well. The outcome is that the RVAD implantation, which would you expect looking at the previous data, is none in the lateral lateral group, where it is and 50% in the conventional sternotomy groups, and 18 in the even non-risk group, which is high as well. And looking at mortality, we see that the high risk group done a lateral thoracotomy is even better off than the non-high risk group, and worse here in this case is the conventional sternotomy group. So now we would just moved from a rather healthy cohort and lateral trial to a high risk group, and now we go even further. This is a study was done in Europe and very recently published by Potapov from the Berlin Heart Center. It's a study source from the ECLS registry in the period of from 110 to 818, and in a population that could not be weaned from ECLS after the determination of the neurological status. And 363 patients whereas 324 were operated on by full sternotomy, less than 39. Interesting here as well, the list was performed in 6 of the 11 centers, with a varying experience of 3% to 46% within one center. So even here, it's not a harmonized group applying this therapy to this morbidly sick patient population. In order to account for imbalance in the list and the full sternotomy group, a propensity score was calculated. If you're interested, just jump into it. I just wanted to display this for scientific correctness. Looking over here, the preoperatively characteristics were statistically not really different, except that the full sternotomy group had more adrenaline on board, and the cardiopulmonary bypass use was very different in the group full sternotomy versus the LIS group. So here, even though on ECLS, the full sternotomy group was converted to CPB in 52% of cases, whereas the LIS group was operated on ECLS in 28.2% of all cases. This definitely is very different in methodology. The devices were used equally with hardware mainly, whereas HeartMate 3 and the HeartMate 2 were hardly used in the list. HeartMate 2 was hardly used, of course, in the list group, even though in one. So what do we see over here? That the survival in the less invasive groups is better, even though it is, it is better compared to the full sternotomy group, even though it does not reach statistical significance here. By just looking at the graph, you will appreciate that there is, well, a trend. I know scientifically a trend is not really important, but just looking at that. But here you will see as well that the total blood products used is significantly different in the LIS group versus the full sternotomy group. The rest is nearly the same, whereas the 1-year survival differs from 54% to 71%, being it not statistically significant, probably to the imbalanced patient groups. Okay, now Another one, and this is more the last one, but these are the largest population one can go at, one can to speak about. It's a multi-center retrospective cohort study across 5 centers. It's 430 patients, list 122 and conventional 305. Düsseldorf, Leipzig, Minnesota, University of South Carolina, Johns Hopkins. The primary outcome was severe and severe acute. I'm sorry for the misspelling. Right heart failure by Indomax deficient. Definition, secondary outcome to all-cause mortality, transplantation rate, temporary RVAD support, and of course the 2 groups were propensity matched by age, sex, Indomax profile, balloon pump, and ECMO use. And here we see here as well the off-pump implantation. When you just look at the bullet points, the off-pump implantation was very frequently done in the list group, was more often done in the list group, not frequently, it's 12%, and the device type choice has been different, whereas the list group is mainly provided by the HVAD, whereas the conventional sternotomy group is done by the HeartMate 3. There are no other propensity matched p-value differences in all the variables that you can look at. But very interestingly, you see over here, this is a survival by a strata by right heart failure, yes or no. We see as well in the non-matched group, which is always A, and the propensity matched group, which is B. There's a significant difference whether you have a right heart failure. But interestingly enough, the entire cohort does not demonstrate a different survival. This is something that has not been explained, and something that I did not expect, but it came out that way, and it is well within this JHLT just being published in April, so it's even hot. So looking at that, you can see that the list cohort is postoperatively less explored, so we have less bleedings, and we have less right heart failure as seen in the graphs before. So this is a consistent throughout the entire groups that we have less bleeding, and then we have less right heart failure, and we require definitely less RVADs. So in summary, a less invasive strategy for LVAD implantation may be associated with a reduced risk for early right heart failure. There was no difference one-year mortality between the 2 strategies. Our data suggests that the list strategy is alternative to a conventional. So just alternative, not superior. Nobody says that so far. Future studies should include a comparison of these strategies in those with higher risk or post-operative right heart failure, especially a randomized control trial. And this is what we really need, because we know that the first reports were in 2012 with the HVAD, and now it's 10 years later. Comparing the conventional sternotomy with a list strategy with a structured implant protocol is warranted and necessary. Now we jump to another field, and this is transplantation, and this is a publication that very recently done by Daniel Zimfer's group from Vienna, another giant in the field who just has paramounted the minimal invasive implantation as well. And he just compared the outcomes of transplantation of patients who had been in a full sternotomy, who had implanted full sternotomy versus LIS. And interestingly, you see here on the survival is phenomenal over the first year, with a 1-year survival that is, a 1-year survival in the full sternotomy is 95%, whereas in the LIS is 93%. But the difference is here that is the donor-specific antibody formation is very different in the LIS group versus the full sternotomy group, and this reaches statistically significant. So the immunological profile has changed according to the implantation type. And the implantation technique over here is the multivariate Cox rational analysis has demonstrated that LIS versus full sternotomy has a better immunologic profile, But also while looking at the cohorts compared, then higher grade rejections cannot be found in either one. So even though there was another immunologic profile, it did not lead to a higher rejection rate in the full sternotomy cases as well, it did not lead to a lower or even higher survival. So here we also have observed excellent post-transplant outcome. LVAD patients undergoing heart transplantation in present study. Less invasive VAD implantation reduced the risk of immunologic sensitization. Longer follow-up will determine whether this will impact long-term survival and develop graft vasculopathy. So here as well, we have hints that this is superior, but we cannot say that it definitely is. There's one caveat I would like to just mention now, and this comes from a thoracic surgeon. This is a personal communication, and the gentleman's called Akil et al., and he will publish a paper right now in print in Journal of Thoracic Disease, and he quoted that you're inducing a thoracic disease when placing a mechanical assist device into the pleural space, and I have heard these from other senior surgeons in the field as well. So they report on high incidence of pleural effusion in multimorbid elder patients with reduced liver function, and we have these patients rather frequently. And we have a secondary higher incidence of empyema with secondary pump involvement by transpulmonary infection. Atelectasis, mucostasis, transpulmonary infection will be an issue. At least that's what they fear. So we conclude that the less invasive on and off pump VAD implantation is well established and has become a primary choice in a growing number of centers. It's safe, effective, and reproducible. We can really assume that we have less right heart failure, especially in low and especially at high risk patients, as this has been demonstrated through their entire cohorts. We have less bleedings, and I don't know what this contributes to, since we all know how to do a stenotomy. We have the shorter ICU stays and shorter ventilation stays. We have direct vision to the apex of the heart with a probably better pump placement, and this is paramount for long-term support. And it contributes to transplant ease, whereas apical adhesion may be very challenging. So unfortunately, the scientific evidence remains low. And this is now the end. I would like to thank you very much for your attention, and I'm happy to take questions. I hope I didn't stress your patience too much.
I think that was incredible. That was a brilliant presentation. I think we are very grateful for you to take so much of time and share everything that you probably felt was important for us to not just understand the science, but also realize the real world advantages. I have an esteemed list of panelists, Dr. Gokhale, who needs no introduction, and Dr. Keval Krishan, Dr. Milind Hote.
And
I can
Dr.
see Dr.
Nicholas Doll from Germany.
Nicholas Doll is.
Nicholas Doll. Welcome.
So I'll probably ask Dr. Gokhale to begin and ask Dr. Aistrup to tell us a little more about minimal invasive implants of VADs beyond what he's told us.
Thank you, Sandeep. That's really an excellent presentation by Dr. Sebastian about minimal invasive implantation of ventricular assist devices and the advantages. Like everywhere else in all minimal invasive surgeries, initially things were not very apparent, but over a course of time, the regular other surgeries like valve replacements, coronaries also, we find a lot of advantage. I guess it is a question of numbers. When you have a large numbers, then we find the difference a little more clearly than when the numbers are a little low. Yeah. See, in India, the transplants are picked up and the ventricular assist devices are also numbers are picking up. But however, there are very few surgeons like Sandeep Patawar and Dr. Bala who have got a significant numbers. Many of us have done, and Keval, of course, and many of us have done in single digits. So I guess there is a lot for us to learn in this area. And one question I have is, I missed the answers when you were talking, I think. This is the angle of anastomosis. When you are doing this to the descending aorta and to the ascending aorta and to the subclavian artery, how do you angle it? Is it you angle it towards the carotids, or how do you angle it? Because you don't want it at 90 degrees.
No, 90 degrees you definitely don't want to have because of the shear stress that you will induce. So you angulate it usually in a 60-degree in a 60-degree fashion. You just place it in the ascending aorta, and by visual inspection, you see how you can nicely eject the heart into the arch. So this is how you want to have that. With the descending aorta, is the same as well. But as said, you can use either place from the subclavian artery down to the diaphragm where you want to have it. So I'd rather stay a little higher, because then you have a nicer introduction of flow into the arch as well. Even though some other surgeons even think that you angulate it downwards towards the femoral artery. I have not done that as well, and I think that we may consider that, but we don't have any data that's supporting one or the other way. So I would just, of course, here take a 60-degree angle, try to have a 60-degree angle as well. And as I said before, I would really prefer to do the descending aortic anastomosis prior to the ascending, because it's just in the way. It's just for technical reasons. Going to the subclavian artery, we have nicely shown in the FD flow dynamic studies that in angulation of the angulation of 30 is even better than 60, is even better than 90. But you cannot make 30. You can't make it that shallow. It's technically not possible. So if you end up being around at 60, it's probably the best compromise you can go to, and you should have a little bit excess of the 8mm graft, allowing the arm to lift. When you lift the arm, you see that you angulate it, and you place stress on the 8mm graft, and this sometimes impairs flow within this segment. And as I said before, you do have to partially ligate the axillary artery towards, or the brachial artery more or less, otherwise you have an overflow phenomenon. And this also, I didn't expect that, but the CFD study shown as nicely alters the flow phenomenon proximal to the anastomosis with having less shear, because, well, obviously the flow is nicely guided within the vessel. So that's how I would do that. I try to do so. But you have to be honest, if you have a, let's say for the ascending aorta, if you have, let's say, a patient that had been operated on with a central anastomosis for bypasses, for instance, sometimes you have to try to do it the best possible way. It's not always the ideal world you're going for, but you just cannot reach it. So you have central anastomosis. You don't want to clamp the anastomosis. Somehow you have to fight your way through. You want to stay lateral as much as possible, and this sometimes is not that easy if you make a mini thoracotomy on the right, because then you need to have a little bit more exposure, coming even from a dorsal part of the ascending aorta, just ejecting into the aortic arch, so that you can avoid being interference with the central anastomosis of the cabbages. So, it's always secondary surgery. Or we see more secondary surgery right now. The patient have been operated on one frequently, and we just have to fight our way through. But technically and theoretically, it's as I said.
Do you think this is possible even in redo cases? The minimal access implantation of assist devices like post-cabbage?
Oh, yeah, definitely. Yeah. No, I think this is even one of the main population I used to do the minimal invasive cases in, because the adherence of the right ventricle to the sternum itself, or at least I wanted to dissect the adhesion of the right ventricle to the sternum, with the potential of injuring the right ventricle. So if there is a patient who had been operated upon prior, not just aortic valve, I would favor doing the minimal invasive cases and leaving the right ventricle in place, leave it alone, and don't even touch it, because then you will have, of course, less bleeding and potentially has not been proven, potentially less right out failure, and it's an easier implantation if you do it minimally invasively. Also, let's say if you have an IMA graft. It's sometimes very cumbersome dissecting the plane with an IMA graft in place. And if you do it in a standard fashion and you have to just lift up the apex, you very often cannot lift it up enough, or you place too much stress on the IMA, and you may even tear off the IMA. So if there's a, let's say, on a patent IMA, I would always go for the lateral approach.
So you put it from the LV apex to descending aorta. That's the
No,
easiest
I do.
way.
No. You can't do so. The primary target is still the ascending aorta. You make a J stenotomy, which can easily be done, and it does not need to be a J. It can also be a Y. Let's say if you make a Y stenotomy, for instance, you have more access. It's easier to go to the pulmonary artery. Let's say in case you just stumble into right heart failure and you need to place a graft to a pulmonary artery. And of course, in redo cases, you need to have exposure. We all know that exposure is the key. So you can do that by having a Y if necessary. But it can also be done as a J. And with your index finger of the left hand and the index finger of your right hand, you just form a tunnel through which you can easily push the outflow graft forward, so you can make a normal, regular central anastomosis to the ascending aorta, even in redo cases, without any issue. Can be done easily. Okay.
Well, how important is it to keep the pericardium intact for RV function? We have enough evidence for that?
Well, more or less, the intact pericardium for RV function is considered to be responsible for less RV failure. That's what is being proposed, and there's a paper out there. I just have it over here. I didn't quote it. A paper out here, which is very from Brian Houston, talking about this and say, okay, we have the preload factors versus the afterload factors and the myocardial factors. The one that we can really alter the preload factors to the right ventricle by keeping the pericardium intact. So this is definitely this is something to consider, even because, and mainly because, we don't know what the exact factors are contributing to right heart failure. So we have to take what we get. And certainly it's beneficial to have an intact right ventricle pericardium over the right ventricle. We see in other cases, there had been an MRI study saying that in CABG patients, if we open the pericardium, place bypasses, and do not close the pericardium again, we see that there's a ventral bulge of the RV free wall lasting for at least 6 months. So it can be seen and has been demonstrated on other instances, on other diseases. So it is, I think, a lot more than just a fairy tale saying that the right ventricular pericardium should be left alone. And this, I think, is the secret to what's going on with the LIS versus non-LIS. It's not the sternum, it's the pericardium.
Yeah, I ask you this question, Dr. Sebastian. What is your experience with an intraventricular pump? Do you think that you have reduced incidence of right ventricular dysfunction after VAD implant with an intraventricular pump? I know there are not many around. I believe Heart Assist had an AVAD that they were working on. I believe there were trials with Professor Jan Schmitto, I'm sure with your group too. Likewise with the Java.
You know, I did 5 Jarviks. But now, to be very honest, I did 5 Jarviks at the beginning of my career, and they worked well. Technically, they work well, but they were all on the descending aorta. But it was the intermittent low-speed algorithm that was still used at that time, and the pump was hydrodynamically not very efficient, and it was very thrombogenic. So we had complications not due to RV failure, but we did have complications to other failures around. So this is something that we definitely cannot compare. So I cannot make any remark whether the intraventricular pumps do better. than the extra cavity pump. The AVAD didn't make it, of course. The only intraventricular pump that we have right now, and which I have a large experience, is the Impeller 5.50 or 5.5. There, but that's of course a different story, since it's since it was in place over the axillary artery, and interestingly, we see that there is no right ventricular dysfunction when you implant an Impeller 5.5 via axillary artery and go to full support rather frequently in patients with a very impaired left ventricle and also impaired right ventricle. We even used it, and this is also published, not by the group that I was in, but a group from Brian Lima from Dallas and Baylor Dallas, say that you frequently precondition patients now with an impaired right ventricle with an impeller and see whether the right ventricle recovers and tolerates the flow and the load that is given by the pump. So there may be something to it. It could be that intraventricular pump is a difference, but we certainly don't know on chronic pumps. But it could also be that the access is different and the use of CPP is different. So, but I cannot really answer your question, since the Jarvix that I had did not demonstrate a difference, and the AVAD didn't never make it to market.
Great, lovely. Just a quick thought on the single antigen bead activation and lesser chance of rejection, especially in patients that had the lateral approach. Do you think the power of the study was limited by the fact that the numbers were small, but yes, very promising, I would say, in fact, even with those small numbers? Do you have any comment to make on that?
You know, Vienna is one of the prime centers in VAD and transplant surgery in Europe. We have to say that. They have fantastic results, and scientifically they are superb. Definitely these are smaller numbers, but we do know that in these cohorts, and these investigation numbers remain small. But what's interesting to see is that the use of blood cells by LIS is less than by the conventional approach. And this is consistent throughout the entire publication, the single center reports and the multi-reports. It's very consistent. And obviously, that's the key difference. And well, we also know, when you go back to the transplant time, that, well, you know, the massive administration of blood products is tremendously harmful. So therefore, I think this is much more than just a side effect. I think this is something that is most likely very, very important and may be a game changer in BTT patients. And now this is, besides right ventricular failure, maybe something that really makes a difference and should be considered. And this is probably one of the reasons why BTT patients should be predominantly bridged by a LIS VAD and not a sternotomy VAD. So I think that's more than just a side effect.
Let I also ask you another question. Now that we know that we have the opportunity for a fully implantable VAD, I believe Medtronic and HeartMate, Abbott are working on that option too. The combination of Jarvik and the Israeli company that did the first implants, Leviticus, yes. How would you foresee this as a challenge, or would you see it as an opportunity? Would you have some comments on that?
Well, I did read the article about the status of VAD and transplantation throughout India as well, and they said that you have a waiting time of 3 months, so that's no need for that, more or less, right? But also it had been said that the exit side of the driveline in different climates cause a lot of problems, and of course the care is very, very cumbersome, and it's cumbersome throughout the world. So driveline exit side issues have not been solved, not at all. And therefore, I think, to me, that the fully implantable VAD, if financially feasible, of course, is something that we also have to consider, is the only way to go. It's the only way to go. So we have to eliminate the driveline, and we have to eliminate for infection reasons. We have to eliminate it for quality of life reasons. And this is the item that, well, just keeps the cardiologist from sending these patients to a surgeon to be implanted to use the mechanical support. So we have to get rid of the driveline by whatever means, and it's, I think, one of the last, or at least it's the opportunity and the necessity for MCS that needs to be tackled rather quickly, and not on a prolonged basis.
So, Dr. Dole, you want to make any points and at this juncture, or you want to make a point after Herman's presentation? Herman, you want to add something? Yeah, time is up. And the 2 minutes. Yeah.
Good evening,
Anybody?
Dr. Mishra. So it's a great pleasure and honor for me to join your honored panel.
No, you are cordially invited, Nicholas. I'm grateful that you are here.
So I would like to ask Dr. Schulte-Heistrup a question. I know that he has vast experience and that he has insights in developments of LVADs, and that he also is quite busy in the development of new devices and has insights with the companies. Yes, we all hope and wait for the fully implantable LVAD, but there should be some steps in between, like new surfaces, like connectable drive lines. Can you comment on this? I think they are quite busy right now. And do you have any more insights and information for us?
Yes, there are. The Medtronic has, am I still on? Yes, I am. The carbotane driveline from Medtronic has been recently introduced, and this obviously had led to a decreased incidence of driveline infections. So that is something that's addressed by the companies as well, and Rheinbad and others are trying to come up with a subcutaneous connector for a driveline exchange. We all know that Abbott has these connector externally, but that's just for, more or less, we have to say, for vigorous mechanical destruction of the driveline. The issue is infection, of course, so it should not be an external connector rather than an internal connector, and this, of course, is an approval issue. But there are companies working on that with a subcutaneous connector, whereas Medtronic has introduced the driveline with a different outcome, definitely. So
thank you, Dr. Sebastian. Thank you. Please do stay for at the end for discussion. And now let me welcome our long-time friend Herman. Since maybe around 15, 18 years, we are a friend. We work together in his mix board, and of course now he's kind enough. Now let me ask Dr. Sandeep Atabar to formally invite Dr. Herman Rachel-Spuran, past president of SMICS and past president of ISHLT, for next presentation. Over to Dr. Sandeep Atabar, please.
It's a great honor